Good afternoon, everyone. At the outset, thank you, organizers, for the opportunity. And my mandate today is to discuss the abstracts related with Destiny Breast 03, which is the trastuzumab deruxtecan versus trastuzumab emtansine in the previously treated HER2 positive metastatic breast cancer patients. So the first abstract that I'm going to, or rather the paper I'm going to discuss is the initial publication in EGM by Javier Cortez. So we all know about trastuzumab deruxtecan now. It's an antibody drug conjugate. There's a thioether linkage between Herceptin and a top-1 inhibitor. We know compared to TDM1, it has a much higher content of the cytotoxic payload, very stable in the plasma, broken down within the lysosome of the tumor cell, and has a good bystander effect. TDM1 for some time has been the standard of care in the second-line setting with a PFS which has varied across studies between 6 to 9 months. And we know that trastuzumab deruxtecan in the DB01 study showed significant clinical activity in a very heavily pretreated population. So this led to the trial, which is the Destiny Breast 03. So this was a randomized, multi-center, open-label phase 3 study. Patients with unresectable or metastatic HER2 positive breast cancer who had been previously treated with a trastuzumab taxane in an advanced metastatic setting, or who had progressed within 6 months of the adjuvant trastuzumab ending, could be randomized to the TDXT arm versus the TDM1 arm. Stratification was as per the HR status, prior treatment with pertuzumab, presence absence of visceral disease, and the primary endpoint was PFS. Key secondary endpoints included overall survival. So in the initial readout, these were some of the characteristics that were published. So a significant number of patients were Asians, but before we get too happy, most of these Asian patients were Chinese, South Koreans, and Japanese. The study allowed patients with controlled or pre-treated brain mets to be enrolled, and that formed a significant number. So 23.8% in the TDXT arm and 20% in the TDM1 arm. And nearly 60% patients in both the arms had received prior pertuzumab. So these were the initial results. Progression-free survival as per the investigator, not reached versus 6.8 months for TDM1. At 12 months, 75% patients in the TDXT arm were progression-free compared to 34% in the TDM1 arm, and a hazard ratio very impressive at 0.28. The PFS as per the investigator was nearly similar, median PFS of 25 months versus 7.2 months, and the OS data, at least at the initial readout, was not mature. When you look at the PFS benefit, it was consistent across key subgroups, including those defined by HR status, prior pertuzumab, visceral disease, brain mets, etc. What about response? Very impressive response rates, 80% for TDXT versus 34.2% for TDM1, nearly 16% CR rates, 63% partial response rates, and very few progressions at about 1.1% for TDXT versus 17% for TDM1. Safety summary, adverse events of special interest. When you talk about any grade adverse event, slightly higher for TDXT at 98% versus 86% for TDM1. But when you talk about grade 3 adverse events, both the arms did nearly the same. The adverse event of special interest, obviously, as we've now understood, is the drug-induced ILD, 10.5% in the TDXT arm, 2% in TDM1 arm. Most of these were grade 1 or 2. 2.7 and 7 for grade 1 and 2, but however, there was 1% grade 3 incidence. Most common adverse events leading to discontinuation TDXT is ILD, 8.2%. For TDM1 is thrombocytopenia. And most common adverse events leading to dose reduction for TDXT were nausea and neutropenia, and thrombocytopenia and liver anomalies for TDM1. So the initial conclusion was this was a statistically significant and clinically meaningful PFS benefit, with 72% reduction in risk of progression or death for TDXT versus TDM1. The benefit was consistent across subgroups. OS data at this time was immature. Safety profile was comparable between the two drugs with similar rates of grade 3 adverse events or more adverse events. And the investigators concluded that TDXT could become the standard of care, and it was subsequently approved by most international guidelines and recommended in the second-line setting. So the next abstract or publication is the updated survival data, which was published in the Lancet in 2022, authored by Sarah Hurwitz and colleagues. So this is the updated primary endpoint PFS. Median PFS as per the blinded assessment was 28.8 months for trastuzumab deruxtecan versus 6.8 months for TDM1. Again, one would look at the PFS data of TDM1 and say this is perhaps underperforming compared to what we saw in the Emilia trial. And there are two possible explanations for this. One, perhaps we all understand from retrospective data that TDM1 doesn't do as well post-pertuzumab as it would do where a pertuzumab has not been offered. The other thing is a significant number of patients in this trial were actually not second line. They had many more lines of therapy, and they could be enrolled in this trial because TDM1 was not available in those countries. Overall survival, not reached for both arms, but a hazard ratio of 0.64 for TDXT versus TDM1. So nearly a 36% reduction in risk of death, and at 2 years milestone analysis, 77.4% patients alive in TDXT arm compared to 70% in the TDM1 arm. The efficacy endpoints were confirmed in this updated analysis. Importantly, the median duration of response for TDXT was 36.6 months compared to 23.8 months for TDM1. A significant number of these patients had post-progression treatment. So nearly 70% of patients who had discontinued treatment on account of progression had some therapy, including 17.3% patients in the TDM1 arm who could actually go on to receive TDXT. And this, I think, makes the OS even more impressive. Overall survival, fairly homogeneous results across subgroups, irrespective of hormone status, prior pertuzumab usage, and prior lines of systemic therapy, and presence or absence of baseline brain metastasis. And based on this, the investigators concluded that this OS analysis was clinically meaningful and statistically significant, and the PFS benefit continued to remain so. The risk of death was reduced by 36% for TDXT compared to TDM1, and 78.5% patients of all patients experienced a confirmed objective response rate, and the benefit was consistent across pre-specified subgroups. So coming to abstract 3, these are the patient-reported outcomes from the same study, which were presented at the ESMO Breast Cancer Congress in 2022. So these are the different ways that the health-related quality of life was assessed by different questionnaires, the EORTC, QLQ, C30, looking at global health status, and the main analysis being changed from baseline and time to definitive deterioration. The EORTC, QLQ, PR45, which is a breast cancer-specific questionnaire, again looking at time to deterioration. And the key analysis was also hospitalization based on record assessment, and they were analyzing time to first hospitalization and length of stay. Compliance was fairly good in both the arms, 97% at baseline and 82% at the completion from cycle 3 to 27. So these were the results. Global health was maintained in patients treated with TDXT while on treatment, which I think is quite reassuring. When you look at time to definitive deterioration, this is the TDD. Patients treated with TDXT experienced numerically longer median time to definitive deterioration at 9.7 months compared to 8.3 months for TDM1. And when you look at clinically important aspects like pain, symptoms, and emotional functioning, time to definitive deterioration was also prolonged for these aspects, emotional functioning and pain symptoms, with TDXT compared to TDM1. And importantly, hospitalization related endpoints, median time to hospitalization was more than 3 times longer in TDXT compared to TDM1. However, other hospitalization outcomes were similar in both the treatment arms. And they concluded that overall health status and QOL was maintained with TDXT. TDXT led to treatment delay in time to definitive deterioration, particularly in pain symptoms, and first hospitalization was also delayed with TDXT. So the last abstract, what about the safety follow-up? And this was a presentation by Erica Hamilton and ASCO 2022. So this is the updated safety overview, very similar in terms of the adverse event profile compared to what we saw in the initial publication. Fairly similar grade 3 adverse events for both the arms. And again, ILD was one of the most common reasons for discontinuation in the TDXT arm. They also looked at, interestingly, an exposure-adjusted incidence rates. And quite clearly, we know that TDXT being more effective had a greater exposure. So they looked at this EAIR, where they looked at patients who had at least one adverse events and divided that number by the number of exposure years. And when you calculate that, the actually exposure-adjusted incidence rates were lower for TDXT compared to TDM1. What are the common adverse events that we see? Predominantly hematological and gastrointestinal is what we see with TDXT. We very well know what TDM1 does. I think ILD is something that we are all concerned about. We also looked at time to first onset of adverse events. So time to first onset of adverse event was actually longer for TDXT. Time to first dose reduction was also longer for TDXT. And therefore, I think what's important for me clinically is that you need to keep on monitoring these patients for longer. Now, ILD has been one of the key concerns. I couldn't personally understand why ILD happens more with TDXT compared to TDM1. I think perhaps it's something to do with the cytotoxic payload. Again, ILD was seen in 10.9%. Most were grade 1 or grade 2. Grade 1, remember, is an asymptomatic. So it's basically something you see on a scan. Grade 2 is asymptomatic. Grade 3 is severely symptomatic. And grade 4 is life-threatening. Now, with these numbers, although the numbers appear small, I think clearly as a clinician, we need to be aware. We need to make our patients aware. Look out for symptoms like cough, breathlessness, fever. Have close touch with our pulmonology friends as well. Do scans as and when needed, and actually look at the degree of ILD and treat with steroids, hold back the drug, dose reduce if need be, and stop, especially if the ILD is grade 2 or higher. So the safety analysis concluding that there were no new safety signals. Most adverse events were grade 1 or 2. Risk of nausea, vomiting, fatigue was higher with TDXT, and there was no additional grade 3 or adjudicated side effects. So conclusion, TDXT not only statistically led to a statistically better median PFS, but also a better OS.
Can you give the take-home message quickly in your last slide?
Yeah, so take-home message is clearly this is a standard of care therapy, which has been advised by most international guidelines. The drug is not available in India. Some of our patients who have had access to this drug have actually benefited, but we need to really watch out for side effects like ILD. Thank you very much.